Good morning. This is Jennifer Robinson from Spherix Global Insights, and I'm thrilled today to be talking to Dr. George Bakris, who is professor of medicine at the University of Chicago, where he is also the director of the American Heart Association Comprehensive Hypertension Center. He is, as you may know, an international expert in hypertension as well as diabetic kidney disease, and he's been the principal investigator on several clinical trials. I'm fortunate to have him here today to talk a little bit about SGLT2 inhibitors among nephrologists and what's on the horizon for diabetic kidney disease. So why don't we kick it off, Dr. Bakris? As you know, we have been tracking the nephrology uptake of SGLT2 inhibitors since Invokana was approved several months ago. And we are still seeing that about a third of nephrologists say they have some trepidation about prescribing these drugs. So all this great data, what's your reaction to that?
Well, it's interesting. I've heard the same thing directly from nephrologists. And you hear everything from it's not my job to manage diabetes to I don't want diabetic ketoacidosis to I don't know how to manage the side effects. I don't want to manage side effects. Forget it.
Mm-hmm.
So I think that, and by the way, this has been a problem since the inception of these drugs. In fact, in 2019, I was contacted by the editors of the American Journal of Kidney Diseases and specifically asked to write an editorial perspective. And the quote was, get our colleagues off their dead asses and start prescribing this stuff. So, and of course, that was 2019. We didn't have as much data as we have now. And so that's that. I think fundamentally, and by the way, there were the KDIGO diabetes guidelines, which were published in 2020.
Mm-hmm.
For the first time, actually had very specific recommendations on management of glucose.
Mm-hmm.
And a lot of nephrologists were aggravated about that. They talked to me about that and said, look, we're not managing glucose, forget it.
Mm-hmm.
So I don't know why they put that in there. So I think a lot of people, the people that are not using it are either A, not really familiar with it. They say they are, but they're really not familiar with it. Or B, the fear of side effects is there. And when you bring up the trials to them, they will immediately point to, well, see, there were side effects there. And, so you're not going to get everybody on board. And the other thing is, by the way, the nephrologists in general in this country are seeing people once they've lost about 80% of their kidney function.
Right.
And while these drugs may be useful there's some evidence that they may be, the real push is when cardiologists, endocrinologists, and primary care see these patients when their GFRs are still 40, 50, 60.
Mm-hmm.
Most nephrologists are not going to see them that early. So I think if you actually look at the nephrologists not prescribing it, they're the dialyzers. They're the ones that have 85% of their patients on dialysis. So as a consequence, they're not prescribing it.
I see. And that's interesting because one of the things, and actually it was at your prompting that we included in the survey, was around the GFR at which they would initiate an SGLT2, and then also when would they stop treatment. So we get feedback, just as you were saying, GFR of a mean of about 57, but then a mean discontinuation of about 25.
Right.
Does that, and what's interesting, it hasn't changed in about 18 months. We actually had thought, we might see that discontinuation kind of go down a little bit to be in line with the label. We really haven't seen a lot of movement. So what's your reaction to that?
Well, with all due respect, most of us don't pay attention to the label. I mean, I do because it comes to me, it's in my face in the emails. But most practicing physicians are not reading the PDR, or they're not worried about FDA announcements. So they're going to stop using it when they think it's probably not going to be useful. And my guess is it's probably around 35, 30. That's probably where they're going to cut it. Most of them are going to cut it off.
Okay. So as they're starting to get into stage 4, just kind of
starting to get to stage 4, forget it. Now, there are studies that are starting in Europe on dialysis patients with SGLT2s. There's not outcome trials, but they're small studies. If those studies come back positive at some level, then you're going to see the change. Until then, amongst nephrologists, you're not going to see the change.
You're saying kind of status quo. So the onus is really going to be on educating the primary care physicians, cardiologists, and endocrinologists.
Yep.
Do you see
Well, the
that happen?
endocrinologists, I think the endocrinologists are on board. I think the only issue for them is cost, but everybody else probably needs some education. Yeah.
Okay. And I was going to say, you know, from the cardiology perspective, do you see those attitudes changing among your cardiology peers?
Again, yes, definitely. There's always the early initiators, and then there's the later ones. And I think the concern that has emerged, and I'm speaking now in my institution, cardiologists, a handful, and the preventive cardiologists are the ones leading the charge. They're using it. What's happening is some general medicine people are using it. However, I don't think they fully understand who can develop diabetic ketoacidosis and how you can prevent it. So we're now starting to see an increased risk, or not an increased risk, an increased incidence of diabetic ketoacidosis with the increased use. So there's a beautiful paper that was published in the BMJ not too long ago, actually very recently, on diabetic ketoacidosis and its avoidance when you use these agents. And I think that really needs to be circulated, and maybe a 5-minute podcast done on that so people can pay attention to it.
Interesting. You know, I'm wondering with cardiologists, I'm going a little off our script here, but are a little bit like nephrologists too, that I don't want to manage the diabetes. Does that come into play?
There's definitely that. And in certain subgroups, the electrophysiologists, that is not what they do. That's not in their bailiwick. The interventionalist, yeah, it's a great idea, but somebody else can do it. So you're not going to get everybody on board. But if you get the preventive cardiologist on board, that's a big deal, actually, because there's a fair number of them. And then their colleagues are not going to change things unless it's very specific to a problem. So I think that's a good way to go.
So do you see in 3 years from now, do you see the promise of these drugs really slowing progression, really making an impact? How long do you think it's going to take to kind of turn this barge?
Well, I think we already have evidence that it's doing that in clinical trials. Now, in terms of waiting for the epidemiology to catch up with the clinical trials, I think it's going to be every bit of, well, let's see. I would say the data from 2025, 2026 is going to start reflecting this. If somebody carefully looks at this, because by then you will have had at least 5 solid years of use, and then maybe more, and then we can see actually what has happened. But I think the concern, and I just saw this last night in an ADA session that I did, based on the questions coming in, I think there's concern that these people that are using these drugs do not fully understand them, because the question was asked, can I substitute them for ACEs and ARBs? Now, if you really understood the drugs, you would never ask that question.
I'm not a nephrologist.
Well, even a cardiologist or general internist wouldn't ask that question if you really understood what ACEs and ARBs do. And the other thing is 100% of the trials were on background ACEs and ARBs. So the fact that today you're asking that question worries me.
How do we get these physicians educated?
I don't know the answer to that. In the old days, I would have told you, well, you need more CME programs, you need this, you need that. I think that you need that. It's not that you don't need that. But I think really what's happened to medicine today, and I hate to say this, but it's true because I see it. It's gone from an intellectual, thoughtful, Columbo type exercise where you're putting things together and coming up with something, to a Food Network, Bobby Flay kind of, what's the recipe? How do we do this? And why is it happening? Well, there's a subgroup that's going to ask that, but the majority just want to know what the recipe is. And so I think you're going to have to put together, and this has been done. We've done this in the guidelines. You're going to have to put together some kind of paradigm where it's abundantly clear that you're not substituting one for the other, and something that's easy, You can Xerox it, put it up in exam rooms so the nurse practitioner can follow it. And I'm sorry to be pejorative like that, but that is what I see has happened.
There's a lot going on. So let me ask you this, now that you bring it up. Some of the feedback that we've gotten is, these drugs are clinically interchangeable. One SGLT2 is, just as good as another SGLT2. What's your reaction to that? Do you see them as unique, or do you see them as clinically interchangeable?
No, I mean, pharmacologically, they are different. Okay. But I would say that I guess the best analogy I could give you is, well, I can't really give you that analogy because that's not true either. That they're very similar. And while pharmacologically they may be a little different, the outcomes are the same, the side effects are the same. There's really no substantive difference other than the pharmacology, maybe the half-life. That's about it.
And do
So,
those
so for
really
me,
translate into any clinical differences?
no, they don't translate into any clinical differences. And I will tell you, I was there and on ground zero in 2008 when Bristol Myers had DAPA. Okay. And then they rushed through it. And then the rest of the story. So I think if you really look at everything in the totality, and of course, people are going to kill me for saying this, which one's the cheapest? Which one can the patient afford? That's what you give them. Simple as that.
I appreciate the candor and the honesty. It's what it is. It's the world we live in, I think, with managed care
Yep.
as well. In terms of kind of looking forward, so that's the SGLT2s. We are anticipating possible approval of finerenone coming soon. Where do you see finerenone fitting into the treatment paradigm for DKD?
Well, let me give you a broad picture, and then I'll hone in on that. First of all, the anticipated PDUFA date is July 9th, so it's around the corner.
Right.
So that's number one. Number two, nephrologists for the first time in 20 years are turning into cardiologists, or at least heart failure cardiologists. And what do I mean by that? Heart failure cardiologists now have a panoply of 4 drugs that they can use, and they can use them all together depending on the patient, but they've got to interchange and can use 4 drugs. Nephrologists never had that. We had ACEs and ARBs and we're done. Now we've got ACEs and ARBs, we got SGLT2s, and we have non-steroidal, I want to emphasize non-steroidal, mineralocorticoid receptor blockers. And stay tuned, we may have the GLP-1 RAs 2023. We'll see what the results of the trial are, et cetera. So we have a lot more that we can do to slow nephropathy progression. And it's a matter of how do you do this? So what do the mineralocorticoid receptor blockers bring to the table? Well, they bring a fair amount because they bring safety first. They're a lot safer than a finerenone or spironolactone. They're a lot better tolerated. And you're getting an effect that is actually, I don't want to say independent, but almost independent of blood pressure, where the others don't give you that. And so, and you're getting SGLT2s do have some anti-inflammatory effect, there's no question, but you're getting a lot of anti-inflammatory effect with the non-steroidals. And there's data published now, animal data, but there's data published that they have additive benefits on albuminuria, on slowing progression of the morphology of the disease. So I think everybody wants to say, well, do I use that first? Do I use this first? I think guess what? I hate to bring up this 5-letter word. You have to think. You have to see the patient for what they've got. Now, if they've got a real problem with hyperkalemia, well, there's no question you'd use the SGLT2. If they've got no problem with potassium and they've got no problem with blood pressure, you could use the MRA. There's no reason to use the SGLT2. So I think, especially if they don't have an issue with glucose, because you're not going to get any glucose benefit. So I think it depends on the patient. I think in most cases, if you have a patient that maybe has a potassium problem, maybe not that bad, their glucose is under reasonable control, but they still have 300-400 milligrams of albumin, absolutely you'd use the non-steroidal MRA. You're not going to get more blood pressure. You'll get more albuminuria reduction. and you'll get enhanced protection.
Mm-hmm.
So I think that's where we are today. And
Mm-hmm.
you have to decide, where you're going to go with that.
Yeah. Do you, those nephrologists that are having the trepidation with the SGLT2s right now because they don't want to manage the diabetes, they don't like the glucose piece, do you see them being more comfortable with finerenone?
Well, they definitely will be more comfortable with finerenone because the only thing they're going to have to worry about is potassium, and they've seen potassium issues their whole life.
Mm-hmm.
Now, if the potassium issues are pretty easy to manage, which they are, I can't imagine that they would have a problem.
Mm-hmm.
So I think realistically that there should be better uptake there than not. And I don't think they're totally convinced yet.
Mm-hmm.
I think at the end of the summer, without sharing anything more, all I can tell you is by the end of the summer, there's going to be a lot more data that's going to be revealed. And I think by the end of the summer, people are going to be more comfortable. But until then,
Mm-hmm.
there's some concern.
Great. Well, last question for you.
Okay.
ASN coming up in the fall. I think it's still planning to be a hybrid meeting. What are you most excited about?
Well, we're going to be presenting some pretty in-depth renal data from both Figaro and Fidelio combined. And the data, as I've seen the cuts so far, all I can say is if you think Figaro and Fidelio are exciting, wait till you see them combined, because you've got a lot more people and a lot of issues that people are saying, well, yeah, it's there, but no. Mm-hmm. I don't know that they're going to be saying that after they see this data. So I think there's not a lot of other new things that are pending this year. ASN, if you're waiting for clinical trials, you have to wait. So there's going to be a lot of smaller things that are coming out. But I think more data from this trial, from these trials, this program, I think is going to be exciting. And there's some data on anemia that's going to be coming out that should be interesting. And I think the biggest thing is going to be how are they going to handle a hybrid meeting, because they've already got me doing stuff on Zoom. But if I'm presenting these things, then I'm going to have to fly to San Diego. It's going to be interesting. It's going to be interesting.
It has certainly been an interesting year, without a doubt. I want to thank you for taking the time with me this morning and giving me a little bit of a preview to this. It's certainly exciting and nice to see some new options coming to the market for these patients and hopefully improving the care. Thank you so much for your time, and we'll be talking again soon, I hope.
Thank you, and it was a real pleasure.
Take care. Bye-bye.
Bye-bye.